Today's PowerPoint will be on the foot and ankle. As you recall, the ankle is made up of the tibia and the fibula forming the mortise and both of our medial and lateral malleolus. And then the talus, one of the tarsal bones, articulates with this mortise. You see listed there that the fibula is not a non-weight bearing joint, and for clarification, it's not the amount of weight bearing that the tibia takes, but it does help support the weight, and so it is totally not non-weight bearing in a standing position, especially if we are on a foot that is supinated, or more of the weight shift to the lateral side of the foot. This slide is showing you both the superior and the inferior tibiofibular joints. The superior occurring just distal to the knee joint that occurs at the tibial plateau, and then the distal one, as we've been discussing, making up the joint or the mortise for the ankle joint. Here you can see the articulation of the ankle joint with the mortise with the talus. Also listed on the slide are the 7 tarsal bones. In the upcoming slides, you will see them labeled in the foot for you to review. In addition to the 7 tarsal bones, the foot also has 5 metatarsals and 14 phalanges. Other things to consider: that the anatomical midline of the foot is at the 2nd metatarsal. And if we can recall, where was the center of rotation at the in the hand? It was actually the 3rd metacarpal, or at capitate, correct? Also, just knowing that the sustentaculum tali, it's actually located on the calcaneus. It's a bony prominence on the calcaneus that actually helps to support the weight of the talus. It is on the medial side of the foot, and if you can look at the skeleton in the picture, you can see it right there. It is on the distal portion of the calcaneus, just right inferior to the talus, and we can practice locating that on the skeletons in class. The ankle joint, or the talocrural joint, is made up of a mortise that is created by the distal tibia and fibula, which then articulates with the talus, one of the tarsal bones. If we think about the arthrokinematics of this joint, the talus is a convex surface moving on the concave mortise created by the tibia and fibula. So according to our convex concave rule, the roll and the glide are going to be in opposite directions. So this joint has motion, so the talocrural joint only has motion into dorsiflexion and plantar flexion. So if we dorsiflex in an open chain, we are going to have the roll will be in an anterior direction and the glide will be posterior. We will then have the opposite for plantar flexion. The roll is posterior with the glide anteriorly. You also see a review there of ligaments, some that are on the plantar surface as well as the medial and lateral surface of the ankle. You can utilize your Norkin and White textbook to review those ligaments. We will also discuss them a little further when we talk about ankle sprains. The foot has many joints that allow for the flexibility of the foot when needed, say walking on uneven terrain or a rocky surface. Our foot can adapt to that surface, and then also at times it provides us a stable, rigid lever arm for which we can get power to be able to run and jump. So if we look at these joints, if we say the subtalar joint, which is between the talus and the calcaneus, or you could say subtalar below or under the talus, this joint allows for just inversion and eversion at this joint. And we will actually measure this little bit of motion of inversion and eversion at the subtalar joint. And then if we look at the mid-tarsal joints, which consist of the calcaneal cuboid and the talonavicular joint, these joints allow for inversion and eversion as well. And they were what we would call the transition or the link between the hind foot and the forefoot. The TMT or tarsal metatarsal joints are the tarsal bones with the metatarsals, and they allow for some flexion and extension as well as some abduction and adduction and a little bit of rotation. We will not be measuring any motion at the tarsal metatarsal joints. The MTP or the metatarsal phalangeal joints allow for flexion and extension in AB and adduction. And in class we will take a look at the great toe and looking at the MTP joint and measuring specifically extension. And why do you think we might be measuring extension? Think about gait and what is required at terminal stance and gait. Yes, we must have great toe extension, so we will measure that joint. And then we also have the PIP and DIP joints, which allow just for flexion and extension. Then you can also see that the foot has 3 arches. It has 2 longitudinal arches, which are the medial and the lateral arches, and then the transverse arches, which are right along the base of the metatarsal heads. So when you look at the pictures to the right side, and you can see where it's a pes cavus or a high arch, or the pes planus, which is a flat foot, they are talking about the longitudinal arches at this point, and we are seeing it from a medial view. So we'll maybe look at some and see if we have anybody in the classroom that has a high arch or a flat foot, and look to see what that could impact on function. Please review the bones in the foot. We will palpate some of these. Obviously the calcaneus is easy to palpate, and the talus. And then we will also palpate the navicular. The navicular is often a landmark that can be used when a person has a pes planus or a flat foot, that navicular will drop. So please take a moment to review. Also, please review the nerves that run to the foot and the muscles that they innervate. This is stuff that you've learned in anatomy class this spring. This slide reviews the muscles in the lower leg. As a reminder, the gastrocnemius is another 2-joint muscle that it affects the knee and the ankle. Its main action that we think most of is plantar flexion at the ankle, but also assists in knee flexion. Please review all of these muscles and their attachments. That will help you to distinguish the motions and when we are doing our manual muscle testing for strength. This slide shows both the anterior and posterior tibialis. And to know that these muscles both work for inversion at the ankle. Part of that is to their distal attachment, with the tibialis anterior coming to the medial side of the foot and attaching at the base of the first met head, and the posterior tibialis coming medially as well and attaching at the base of, has a navicular attachment as well as other tarsal bones, but again it has that where it comes to the medial side of the foot, so as it shortens they will both perform inversion, and then obviously tibialis anterior will do dorsiflexion and posterior tibialis will do plantar flexion. Here is another slide that is showing you the pathway and the location of tibialis anterior. Here is another slide to review the musculature from an anterior view of the lower limb. Even though the gastrocnemius is on the posterior aspect of the lower limb, you can see it from the anterior side. Here is a view of the peroneus longus and brevis. Both of these muscles will do plantar flexion and eversion. You see that it's the eversion is because it's on the lateral side of the foot, and it goes posterior to the lateral malleolus, and then the pronatus longus actually attaches at the first metatarsal on the plantar surface. That picture can be a bit misleading. It's trying to show you its location, but it is actually on the underside of the foot, or the plantar surface of the foot. So both these muscles work to perform eversion and plantar flexion. This slide is a reminder of the 4 layers of the foot and how many structures are involved and located in the foot, and just to give you an appreciation of the intricacies of the foot. Please review. We will now discuss some common clinical conditions of the foot and ankle. The first condition that we will discuss will be ankle sprains. Who in the class has not had an ankle sprain? Well, the ankle, it is a pretty stable joint created by the architecture of the mortise, of the distal tibia and fibula, and then the additional ligaments to help provide stability at this joint. There are both medial and lateral ligaments at the ankle. The medial ligaments is called the deltoid ligament, and it is actually a combination of several ligaments that is just usually referred to as the deltoid ligament. The position of this ligament prevents eversion of the ankle, and it is a very thick ligament that doesn't often get sprained. And if we think about it, how do we normally turn our ankle or sprain our ankle? It is more of an inversion sprain, so we don't usually have to rehab the deltoid ligament too much. Now the ligaments on the lateral aspect of the ankle are the anterior and the posterior talofibular ligament and the calcaneal fibular ligament. So these 3 ligaments together work to restrict inversion of the ankle, and again, they are the most frequently injured just because of the mechanism of injury, an inversion sprain. When we talk about sprains, and we've discussed them before, there are 3 grades of sprains for the ankle. So a grade 1 sprain would be some mild stretching to the anterior talofibular ligament. A grade 2 is going to be a disruption of the anterior talofibular ligament and some maybe partial tearing of the calcaneal fibular ligament. And then the grade 3 is going to have disruption of the anterior talofibular ligament, the calcaneal fibular ligament, and there'll be some type of involvement of the posterior talofibular ligament. So early on, clinical management of any of these ankle sprains will be to protect the area, whether it's through taping or splinting, so that they are not going into that inversion motion. Again, we're going to use RICE. We're going to have rest, ice, compression, and elevation. These would be patients that would benefit from a contrast bath that you learned in the first semester, and learning how to, when you learned your wrapping technique for decreasing swelling. Also really instructing them to stay off that foot and to prop it up so that it can decrease some of that inflammation. As it heals, we will progress to exercises. Now we will at the end do all of those in the dorsiflexion plantar flexion plane first, and then we will progress to exercises of inversion and eversion. If they do have a grade 3 sprain, they may need to be immobilized either with a walking boot, so that it can require or allow it to heal. And if instability persists, the patient may require surgery to repair the ligaments. In the top corner of the slide, you can see pictures of a grade 1, 2, and 3 inversion ankle sprain and the disruption of those ligaments as discussed in the previous slide. You can see the mechanism of injury there in the bottom corner of turning their ankle, maybe whether it's shoes that they're not used to, a sporting event, stepping on an unstable surface or uneven terrain. And then you can see in the upper right-hand corner, when you do have an ankle sprain, there is a lot of damaged vessels, and so it will turn quite purple once it's occurred. And then the bottom again is showing you an inversion ankle versus an eversion ankle sprain. Achilles tendonitis is inflammation in the Achilles tendon or the gastroc tendon as it inserts on the calcaneus. It usually is a result of an overuse syndrome, and it is very common in runners. It occurs too with that eccentric contraction of the gastrocs. So when is the gastrocs working eccentrically during running? That's right, the gastrocs slow down the progression of the tibia over the foot. And so even when we're running, it's going to work at a greater intensity to decrease that progression, or to control the progression of the tibia over the foot. It also can be contributed just to poor gait mechanics when they're running, or training conditions. Maybe even not their footwear doesn't provide the support that the person needs. But they are going to have pain to palpation about 1 to 2 inches from the insertion onto the calcaneus. It may even be tender right at the calcaneus as well. Often these patients will have excessive pronation when they're running, or even in the static standing position. This will often occur. People may have been running for a while, but if they increase their activity or their training, and because of this irritation, we'll often see a loss of motion into dorsiflexion, because that's where we would putting that stretch or the stress on that area. They're going to complain of pain and weight bearing, especially climbing stairs, jumping, running. We will in clinic make sure that they do have the proper footwear. Maybe we need to have them get orthotics so that their foot will be aligned properly while they run. But while they're in that inflamed stage, we're definitely going to have them rest and try to use modalities that will decrease that inflammation, whether it's cryotherapy or iontophoresis. And then we'll work some gentle passive stretching. And these are those people who are, they're very active and running, so you should also give them some type of cardiovascular exercise. If you're wanting them to not run, give them an alternative. Otherwise, they'll probably still try to run and maintain their level of fitness. So give them something that they can do, and then you'll get them back to running. Hopefully with improved gait mechanics and proper footwear, or even just discussion of proper progression and training. Medial tibial stress syndrome, or what people refer to as shin splints, begins with a musculotendinous overuse on the anterior aspect of the lower leg, and it also may affect the posterior as well. So it's the tibialis anterior or posterior, most commonly tibialis anterior. It can come from an excessive eccentric overload. So if we think about the gait cycle with running or walking, how is the tibialis anterior active eccentrically? That's right. From heel strike to foot flat, the tibialis anterior eccentrically lowers the foot. So this can cause an inflammation or irritation. Also comes from, when we look at other contributing factors, foot biomechanics. So if a person overpronates, that also will lead to the stress on this anterior tibialis. Also, if a higher body mass index or obesity, increasing the forces. This can progress beyond musculotendinous inflammation and actually lead to a stress fracture of the tibia. So signs and symptoms, our patient is going to have pain right along the tibia, the lower part of the leg. It's going to have pain while they're active and any type of resisted dorsiflexion. and also resisted plantar flexion with inversion. Now that would be if it was the tibialis posterior. They will typically the pain will decrease with rest, but if they continue and do not do any activity modification, it will increase so that the pain is more at a constant, or more than they won't have complete pain relief at rest. So in the clinic, we're definitely going to use modalities to decrease their inflammation, using our cryotherapy and ionto or phonophoresis. We're going to really try to educate our patients to rest, to allow that inflammation to decrease. So this might be, again, that type of person who needs another activity, whether it be biking or swimming, so that they can still get their cardiovascular exercise and keep their fitness level. They also, if they do tend to have overpronation, we may need to recommend that they get custom-made orthotics so that their foot will be in a good mechanical position. There are 3 types of ankle fractures. Malleolar, which is a fracture of either the medial or the lateral malleolus. Bimalleolar, which means that it is both the medial and lateral malleoli that are fractured, or trimalleolar, which means that both malleolar are fractured, and then in addition the posterior tibia margin is also fractured, which you can see in that bottom radiograph. You can see the fractures at the malleoli as well as the one going across transverse of the tibia. Depending on the severity of the fracture, whether the fracture is displaced, if the fracture is not displaced, then the treatment will be to immobilize the patient and have them be non-weight bearing, usually for a total of 4 to 6 weeks. Unless there is displacement or increased severity, then the patient, maybe there are some torn ligaments as well, then that patient is going to require an ORIF, open reduction internal fixation, and then will still be immobilized and non-weight bearing until healing is confirmed. So in therapy, we may see these patients in acute care right after surgery, and then at that point we are teaching them safe mobility with crutches or walker, whatever would best fit that patient, and making sure that they are able to transfer and ambulate while maintaining that non-weight bearing status. Once the cast has been removed, then we will be trying to progress, because they will have lost some motion and strength just by being immobilized for 6 weeks. So we'll work on getting that stretch, that range of motion back, maybe use some modalities to decrease any edema or inflammation that occurs, especially as we try to stretch these patients. We'll do strengthening, open chain, and then progressing to closed chain and resisted exercise. We'll also want to include the knee and the hip and in our exercise, and make it a more dynamic exercise for the lower extremity. We can also do joint mobilizations. Now again, joint mobilizations won't be performed until there is confirmed healing by radiograph of the fractured site. Also at the ankle, we want to make sure that we're doing activities that are going to incorporate proprioception. So whether they're standing on using the BAPS board or a BOSU ball or a foam cushion, something to try to get those little balance adjustments within the ankle, try to strengthen their ankle strategy again. Plantar fasciitis is a very common condition that is seen in outpatient physical therapy clinics. It's an inflammation of the plantar fascia, which is on the plantar surface of the foot. Oftentimes, patients will complain of pain along the medial calcaneus, and then also along the medial border of the fascia. Things that contribute to this condition, it is typically an overuse syndrome. So those that are running, tennis, anything with explosive power starting off will have that inflammation in the plantar fascia. It's because that plantar fascia is usually a shock absorber. So when we are performing these quick activities, is where we're putting the stress on that tissue. Also, if our patients have a normal pes planus or pens cavus deformity, so meaning the higher the low arch, could put more stress on the plantar fascia, whether they're coming down into a flat foot, that plantar fascia is being stretched, or if they have a high arch, then every step that they take that they are getting, they're going to feel stress on that plantar fascia because it is more taut. Also, if they have tight heel cords or a tight Achilles tendon, so making sure that the gastroc and soleus muscles are stretched. These patients are going to have pain, and often they'll complain of pain most often when they wake up in the morning and put their feet on the floor or following rest. They tend to, as they do their activity, the pain may subside for a little bit, and then it comes back and increases when they are resting. So sometimes it's hard to get that patient to understand that they need to modify their activity while it's inflamed, because they'll often say, well, once I get moving, it feels a little bit better, but it is still contributing to the inflammation. Sometimes these patients also may have a bone spur that's developed because of Wolff's Law and that pull that the fascia has been having on the calcaneus. So what are we going to do in therapy? We're going to do modalities to decrease pain and inflammation. So this is all our cryotherapy, ionto, ultrasound with dexamethasone, teaching them to do ice massage at home. Sometimes we have them, put a water ball in the freezer that they can roll on. Also, golf balls that you can freeze in that cold and be able to pinpoint the pressure. They may need to have a resting night splint that's going to put them in a good range of motion and stretch so that when they get up in the morning, they don't feel that intense pain as they step onto their feet. They may need to have an orthotic, a custom orthotic, if they've either have the high arch or the low arch, so that it can be supported and not be putting stress on that plantar fascia. We also may be able to use some kinesio taping or other like McConnell taping as well, and to provide support and take the pressure off the fascia.